You have joined the 16th Annual Gathering Symposium for Faith, Health, and Community. Thank you for being here. Engagement tips for today: be present for yourself and others. Feel free to take notes and share with others. Self-care is a part of wellness. Remember to refresh and renew with a drink of water and/or a healthy snack. Our body is designed to move. Please take time to stretch and move every hour. Remember the 20-20-20 tip. That's every 20 minutes of screen time, look 20 feet away from the screen or device for at least 20 seconds. This will help minimize screen fatigue and energy drain. If you have a question, please note that we will use the Q&A and raise hand functions during our designated Q&A segment. You may enter your questions at any time throughout today's event. Other ways to engage: check in using Zoom reactions, and you'll also have an opportunity to complete the event evaluation form. Today's presenters: Wilma Batiste, Pamela Cross, Marian Harris, Dr. Corinne Holder-Jackson, Lonise Ise, David Lee, Dr. James McCray, Pastor Anadele, Dr. Piawa, Sonia Ray, Dr. Kim Rhodes, Crystal Warren, Dr. Samuel Washington. And the program also includes a marketplace of resources and prize giveaways.
I greet you in the matchless and marvelous name of our Christ. Welcome to the 16th Annual Gathering of Faith, Health, and Community. I am so happy to be here on my 16th gathering. 16 years we have come together for the purpose of sharing good news for the congregations we serve. Therefore, I urge you to join me as we begin this meeting, rejoicing in our presence, your presence, my presence, the presence of God's Spirit. I invite you to rejoice with me in the continuity and the continuance of this UCSF church partnership in the Bay Area. I invite you to rejoice with me in the hope for future ministries together. In the name of the one who is the healer and the one who brings into being a new community, a beloved community, I greet you, I bless you, and I pray the blessings and movement of the Spirit upon all of this morning's activities, from each speaker to each participant. May health, healing, and wholeness be brought forth in newness. In Jesus' name we pray. Amen.
Amen, and thank you, Dr. McCray. My name is Wilma Batiste. I'm chair of the UCSF Faith Communities Committee, Abundant Life Health Ministries Network, and health ministry leader at Neighborhood Baptist Church in San Francisco. Welcome to the 16th Annual UCSF Gathering Symposium for Health, Faith, and Community. Thank you for joining us. Now, I will introduce the leadership team for the Faith Communities Committee. Abundant Life Health Ministries Network. Our co-chair is Sister Marian Harris with Glad Tidings International Church of God in Christ in Hayward, California. And co-chair, Dr. Corinne Holder-Jackson with Cornerstone Missionary Baptist Church in San Francisco. Pastor Tony Anadella of Ebenezer Community Church in Oakley, California. Sister Vanda Nolan of First Baptist Church in Pittsburgh and the Contra Costa Health Ministries Network. Gloria Brown, founding chair of the UCSF Faith Communities Committee, and Michelle Mosley, our UCSF staff program manager. Together, we work to facilitate the Abundant Life Health Ministries Network along with partners. We strive to build collaborative partnerships with communities of faith to help develop sustainable health ministries that promote health and help in cancer health, disparities, and improve health. The purpose of the Gathering Symposium for Faith, Health, and Community is to help inform, educate, connect to resources and potential partners so that we all have healthier houses of worship, healthier communities, and help save lives. Together, we make a positive difference. Next, we will hear from and have an engagement activity with Black Fullness. Let's give our attention to Sonia Ray and David Lee, who are the founders and leaders of Black Fullness. The floor is yours. Thank you for joining us. Please proceed.
Thank you, Mrs. Batiste. Welcome, everybody. Greetings. Thank you for the opportunity to be here. My name is David Lee Walker Jr. As Ms. Batiste mentioned, I'm the co-founder and chief strategy officer of Blackfulness. And Blackfulness is an evidence-based empirical mindfulness tool created for us, by us, with a grant from the National Institutes of Health to reduce stress and offer healing justice through culturally relevant mindfulness practices rooted in prayer, affirmation, meditations, breathing exercises, mood check, and so much more. And so we show up in spaces to remind our people that we have always been mindful, and we have an opportunity to add a level of consistency and a level of intentionality to the practices that we already do. And so mindfulness is one of my spiritual practices. Mindfulness has been shown to reduce stress, to relieve anxiety, to have emotional, physical, and biological impacts that support us living our highest and best good. And so today, I am grateful to be able to share one of the app exercises from our app, Blackfulness. And before we do that, I would like to ask everyone to check in. You can choose to check in the chat, or you can choose to check in with yourself using a numbering scale of 1 to 5. 1 being, I'm barely here and making it. 5 being, I'm here, I'm ready, I'm present, and I'm open. And the reason that we ask for mood checking is because self-awareness is a mindfulness practice. Knowing where we are, how we're feeling in any given moment is a mindfulness practice. So I invite you at this point to check in on how you're feeling and to notice what your check-in number is and to not assign any judgment to your number. It is purely information. Your number is neither good nor bad. It is information that helps us know where we are in time and space at any given time. And so as you are navigating internally to check in on how you feel, I am going to get us set up for our app exercise. And before we do that, I ask that you assume a posture that is open to receive from the divine. We've already ushered the Spirit of God into the space. And so now mindfulness is going to create an opportunity for us to really be present with that energetic presence of the divine. And so I invite you to assume a posture that is supportive, a posture that feels safe. I'm going to invite you to close your eyes if you're willing. You can also choose to maintain an open gaze with your eyes maintaining a light gaze. Taking an opportunity to relax any tension that you may feel in your face. Dropping down and allowing that feeling of relaxation and openness and safety to go down your body and releasing any tension that you feel in your shoulders. Releasing any tension in the thighs, the legs, the feet, where we are grounded. Trusting and knowing that we are always rooted, grounded, and supported. And so as we assume this posture of readiness, I invite you to engage in this experience with our Blackfulness app meditation on welcoming stillness.
Welcoming stillness. Although we're often inundated with distractions and encouraged to keep it moving, there's so much power in being able to push pause, to invite a moment of recharge, reconnection, and stillness into our lives. The beauty of stillness is that it's always there, ready for us to access it whenever we need to. For this practice, you can sit or lie down. You can close your eyes or keep your eyes open. If you keep your eyes open, let your eyes relax and your gaze fall in front of you. To settle into the stillness of this moment, bring your attention to your breath and notice the natural flow of your inhale and exhale. Now take a moment to repeat the following phrase silently to yourself. I am here, and I embrace the stillness of this moment. Allow the energy of these words and their intention to ground you to the here and now. Continue to repeat this phrase to yourself. I am here, and I embrace the stillness of this moment. Allow its meaning to further take root in your mind, body, and spirit. Now, let's seal this practice with an affirmation. Despite the noise all around me and the hustle and bustle of life, I acknowledge that stillness is within my reach whenever I need it. And when you're ready, open your eyes, remembering that you can access stillness whenever you need it.
So we give thanks in this moment, this powerful moment of now, where we welcome the stillness that allows us to hear, to be present, to accept the divine right guidance of the one who sent us here. We give thanks for this moment, and we let it be. And so I invite you now to open your eyes, to be here now, and let yourself sit in this moment for a second. September is Self-Care Awareness Month. And taking time with self is an extreme version of self-care and mindfulness. And so for this next portion, I'm going to take us back to a space where we started, or I invite you to check in on your mood on that same scale of 1 to 5. 1 being barely making it, 5 being I'm here, I'm present, I'm ready, I'm aware. And again, the rating is for you to know. And the hope is that when we take an opportunity to intentionally and consistently lean into mindfulness practices, we lean into life the way that we want to. And so I'd like to remind us that mindfulness is in everything that we do. The exercise that we just did leveraged the mindfulness practice of breath work. The breath is the most accessible, easy way for us to lean into mindfulness. Checking your mood, self-awareness, is mindfulness. The fact that we are all gathered today in beloved community for the divine circulation of wisdom, of love, and of truth is mindfulness. And so we encourage you that practice makes permanent, not perfect. The more we practice, the more we're consistent, the more we're intentional, the more powerful the experience is in our lives, and the more accessible is the life that we want to live. And so I'm going to end with one of my most favorite mindfulness practices, which is gratitude. I am thankful to be in this space. I am thankful for this community. And I am thankful for the wisdom that has been shared already and all that will be shared from this point forward. So thank you for the space, and we are complete. Oh, and I have put information in the app, in the chat, for if you want to download the app or get in contact with us. Thank you.
Wow. Thank you, Blackfulness, for leading us through the excellent activity. We all needed that and can use the activity and the information every day. For more information about Blackfulness, please check out their website, the link and information on the agenda program, and the marketplace of resources. Now, we will hear from our director of the UCSF Cancer Center's Office of Community Engagement, Associate Director of Community Outreach and Engagement, and founder of UMOJA Health, Dr. Kim Rhodes. For more information about Dr. Rhodes and her many accomplishments and project areas, please visit the UCSF profile and bio link in the program agenda. Dr. Rhodes, please proceed.
Thank you so much for that introduction, and to Blackfulness for getting us grounded and centered to get this 16th annual, what used to be called the Great Gathering, kicked off and started. It is absolutely my pleasure to be here, and it is my honor to be guided by the work of the Faith Communities Committee in our office and the Abundant Life Health Ministries Network, since they were here before me. You all were here before me. So as many of you know, UCSF is a National Cancer Institute designated comprehensive cancer center. And NCI comprehensive cancer centers play a special role in their communities. They're expected to perform research that's relevant to the catchment area and engage populations within the catchment area in all activities of the cancer center. And the key piece here is about engaging the populations within the cancer center catchment area to guide the work that we do. And as you can see, our logo for our office says, "Nothing about us without us is for us." And we believe firmly that we need to be at the table and every conversation in order to achieve the goals of the NCI Comprehensive Cancer Center in UCSF. So our mission is to eliminate the inequities that drive cancer disparities in our catchment area. And we do that by sustaining community engagement. And we use a year-round, non-transactional relationship approach. That means we're here regardless. We're not just here to do a study, but we're here as a hand to reach to and to partner with. We facilitate equitable community partnerships to promote research as well as service. And we disseminate cancer information, new discoveries, community-based work, community-driven, community-engaged work. And then we advocate for policies within our institution to address structural racism and the social determinants of cancer disparities. But the foundation of it is community engagement. So just to give you a sense of kind of where you're situated and where I'm situated, and understanding how long the Community Advisory Board has been around, I want to just go through this brief timeline with you to emphasize and highlight the importance of the Abundant Life Health Ministries Network. As you can see, our Community Advisory Board was started in 2005 by our fearless leader, Dr. Frank Staggers, and in partnership with Dr. Rena Pasick and Priscilla Banks. Dr. Staggers basically said, we need a faith committee. That was his first pronouncement. And in 2007, the Faith Communities Committee and Abundant Life Health Ministries Network was started. We then added numerous members of the CAB. There are many who have been here really since the beginning. Ms. Wilma Batiste is one that I'd like to highlight, as you know her well. In 2013, after the passing of Dr. Staggers, Baba Arnold Perkins, the former director of the Alameda County Public Health Department, took over as the chair and steward of the Community Advisory Board in partnership with Angela Sun from Chinese Community Health Resource Center. I was privileged enough to be invited in 2018 when Dr. Pasick made the decision to retire as the new director of the office. At that same time, or around then, our co-chair, Angela Sun, passed the baton to one of her mentees, and we had to elect a new co-chair. Barbara Cicerelli served in that role for a couple of years, and she's the director of navigation at the San Francisco General Hospital. In 2020, we brought on new CAB members and new community partners, including the Pacific Islander Task Force, the Regional Pacific Islander Task Force, who have since extended the work of the Abundant Life Health Ministries Network into the network of Pacific Islander churches. We also got hit with COVID, which allowed us, on the bright side, to expand our partnerships across the Bay Area. And then most recently, we brought on two new community partners who work statewide with Promotoras and a group, the Lake County Tribal Health Consortium, which works with the American Indian community in Lake County up north. We also elected new CAB co-chairs as Baba Arnold announced his retirement and Barbara Cicerelli stepped back. And so Miss Roxana Batista and Miss Lisa Teeler, who some of you may know, are our new CAB co-chairs. This has been a long-term relationship. When we talk about catchment area, what we're talking about is the 25 counties in Northern California that surround the Greater Bay Area. It's a 25 county region, as I mentioned. The majority of the patients who are seen in our cancer center come from there, nearly 90%. About a third of the state's population lives in this catchment area, and it's super diverse, as you all know. 16% of our counties in light blue at the top are technically rural. And our current partnerships, as you can see shown in the purple and gold stars, include representatives from nearly half of those counties. So we're engaged across this this vast catchment area. And I do want to point out that the majority of the yellow stars represent Abundant Life Health Ministry Network partners or Faith Community Committee members. In addition to what we have going on in the office, specifically focused on what the Cancer Center is doing, there are lots of other opportunities for the Faith Communities Committee and Abundant Life to have influence, both regionally, nationally, and internationally. Regionally, we have the UMOJA Health Network, which was born out of the pandemic. This represents 3 community coalitions operating primarily in Alameda County, San Mateo, and San Francisco. We conduct frequent Zoom meetings and provide information about the ongoing pandemic, policy changes that may affect insurance, and then we also share and provide opportunities for funding and to get involved with keeping the community informed. But because we recognize the power of that coalition, we didn't stop there. We extended it and brought in all of the cancer education work that you know has been going on for quite some time in our office under the direction of Michelle Mosley. So now we're doing cancer screening, doing blood pressure checks, and as screening for diabetes, and in some cases, distributing organic food boxes. This helps us address the top 3 causes of death for African American people, and that's cardiovascular disease, cancer, and COVID. On the national scene, and there may be some folks represented from this national network, UCSF is the coordinating center for the National Institute of Minority Health Disparities effort to address multiple chronic disease disparities. That network is a network of 33 organizations across the country, 30 big projects that are partnered with community partners, many of those centers partnering with faith community partners. And so how Abundant Life will be influencing that is this concept and this approach of developing health ministries that are sustainable. We hope to expand and provide technical assistance across this network and have already done so for the New York cohort. I really hope they're here today. And then finally, on the international basis, we have the Cancer Grand Challenges Award, which is an opportunity for us to really look deeply into the impact of environmental exposures and how they may drive what we call cancer promotion. We have a team of patient advocates, some of whom I met here before I was part of UCSF, who will be helping us develop everyday language materials to share out with the rest of the community, both nationally and regionally and on an international basis. So just some examples of the ways in which some folks you're familiar with have been involved out in the community, providing the care that is desperately needed to directly address disparities are shown here. You see Miss Wilma up in the left upper corner. I really love this picture because the promotion was around breast cancer, but we combined that with COVID vaccinations and COVID testing on the same site. So I love the picture because she's mixing the UMOJA t-shirt with the pink hat and the resources and materials to inform our community about breast cancer. We've also been out in the community with our inflatable colon. These are activities that you can request potentially to have at your location. And we've partnered, and specifically the faith community has been a strong and persistent and sustained partner of SFCAN, and in particular, the PCAN cohort, or the Prostate Cancer Action Network. Coming off of UMOJA, we also saw that there was an opportunity to host a regular and ongoing meeting. So we do a monthly meeting called the People's Campaign for Cancer Control, where we work together with our some of our Abundant Life Health Ministries Network member congregations, as well as local patient advocates, our public health departments, and the UCSF staff, SFCAN staff, to really bring things together and develop our own messaging around cancer, cancer awareness, healthy lifestyles. So I want to congratulate the Abundant Life Health Ministries Network and the Faith Communities Committee on 16 years of tremendous success. So the question is, how can you get involved to keep this momentum going? So just in line with our mission and helping us get to and achieve our mission to eliminate the inequities, not just the disparities, but go upstream to the inequities to eliminate disparities. We'd like to invite you to join us in our regular public offerings. We have the CAB 2 Chat and Chew. This is an open forum where we bring you speakers by your request. We really value and honor the evaluations that folks have provided for us and the request for speakers that people have and who they want to hear from and what topics they want to hear about. We want to be responsive directly to your needs. This meets on a quarterly basis, and if you'd like to be invited, please email us at hdfcccoce@ucsf.edu, and that may show up in the chat at some point. We also have our ongoing UMOJA meetings in the 3 counties I mentioned. So if you live in those counties and are interested in what's happening with COVID, And then toward the end of the meeting, the other opportunities that are coming forward, we found Black Fullness through this network. And there are many other folks and organizations in the network that you might want to be connected to. So it is a place of convening and connection. Please email us at info@umojahealth.org. Now, in terms of facilitating equitable community partnerships for research, we are starting to incorporate our community advisors and our community advocates in every aspect of our cancer center's work. One of the big areas where there is a major gap is in participation in clinical trials. And part of this is because, as we say in our logo, nothing about us without us is for us. We're not part of developing which clinical trials get opened, whether or not the way they're designed will be convenient for people to actually participate in. And so what we're trying to do at UCSF now is embed everyday people on our committees. Those are the where the decisions are made about which trials should be opened and how they should be conducted. So this is an opportunity for us as regular folks to learn about the process of how these clinical trials come to be, where to find them, how to access them, and then have a say on how to shape what they look like. So again, please email us at our office email address if you're interested in participating. This is open to everyone, not limited to our community advisors. So we'd also like to, in terms of nurturing those partnerships, we'd like to give you access to an opportunity to search for grants for your own organization. So we have a subscription to the Foundation Online Directory. This is a directory that used to be free. It now costs an annual subscription fee. What we do is, if you email us and let us know that you would like to use it, you get a 1 to 2 week opportunity to use a unique password we will create for you to search for grant opportunities. And if you find some that are relevant, we can absolutely help you and support you in the grant writing process. And last year, actually 2 years ago in 2020, we finished a grant writing training. In 2021, there were 20 grants submitted by 17 grants submitted by 20 congregations. After we had trained them, 14 out of the 17 were funded. So please be in touch about this. And then we're also getting started with, and you may hear a little bit about this later, really having a focus on the environmental impact on breast cancer with a specific focus in the Bay Area and in Black women, but we're offering it across Abundant Life. And the idea is to develop health equity advocates and leaders with the idea that Abundant Life heals. This could be extrapolated to other communities, but this is where we're starting. So if you want to be involved with that, we can provide the contact information about that project. And then in terms of disseminating cancer information, please join us in our monthly meeting in the People's Campaign for Cancer Control. You can share your story on one of these palm cards that some of them get turned into billboards, some of them are riding around on BART. So you may see familiar faces across the Bay Area. The goal here is for real people to tell their stories to other real people, because we think that that will have more influence than just the institution telling folks, here's what you need to do in order to stay healthy. So these cards are designed in collaboration with our partners. We can co-brand them with your organization or your congregation if you want to be the touch point. But then we leverage the network that we have built over time through all these community partnerships so that the person who gets the card may reach to your congregation or your health ministry, and then you can reach to us and we can make sure that the person gets navigated into appropriate care. So I want to thank all of the congregations who are here and for taking action to eliminate disparities, and also for enhancing our ability as a cancer center to do what we do. Cancer centers could come and brag about what we offer and all the precision medicine and all the cutting edge technology that we have. But the reality is none of that matters if it doesn't impact real lives. And this network is a model for how we can influence what our institutions are doing and how we can directly have an impact on outcomes in cancer, which have been disparate for decades. Thank you so much, and please enjoy the rest of the great gathering.
Thank you, Dr. Kim, for the great Office of Community Engagement update. For more information about the Office of Community Engagement, check the program agenda and the chat for the website for further contact. Do you know that September is Prostate Cancer Awareness Month? Now, we will hear from Dr. Samuel Washington, who will focus on prostate cancer and his research. Dr. Washington is an assistant professor of urology at UCSF School of Medicine and UCSF Helen Diller Comprehensive Cancer Center. He is also associate chair of diversity, equity, and inclusion, as well as community engagement liaison for the prostate cancer program. To learn more about Dr. Washington and his practice and research, please visit his UCSF profile bio via the link on the agenda. Dr. Washington, the floor is yours.
Perfect. Hello, everyone. Thank you again for the opportunity to present. Here, I want to talk about a few things that have changed with prostate cancer, even in the last 12 months. I do think that this is an area where we all understand that there are problems, but it's only recently that we've started to acknowledge that some of the problems lie on the system and provider side, as opposed to kind of presenting it as a patient issue in many senses. So I'll go over all of that today. I do want to talk about kind of the burden of prostate cancer, what we know thus far, how our guidelines, so the instructions of how urologists like myself should practice have changed, because it's important that there has been acknowledgement of issues in knowing what we don't know. And it's really a shift in how we approach questions and clinical practice that I think are important for everyone to know as we move forward. So for the burden of prostate cancer, I think we all know that prostate cancer has a large burden on the population overall. But that burden is disproportionate for African American and Black men within the United States, both in terms of cancer diagnoses, where it's over a third of the new diagnoses per year. And it remains the second common cause of deaths, both for African American men and the overall population. But again, a disproportionate amount of Black men are dying from prostate cancer compared to other groups. And we know that that is not just based on one thing. There are different factors coming together in causing this higher rate of death for prostate cancer. It's issues around screening, issues around the onset, so when prostate cancer is developing and when it's getting diagnosed. And then also the quality of the care that's being given. So after patients are being screened, after men are being diagnosed, what type of treatments are they getting? And it really leads to the urology group and the medicine field overall having to change how we practice and acknowledge a few issues that have caused barriers from our standpoint, increased burden on the patients. So a lot of times we talk about screening for prostate cancer with what I call the urologist handshake, the digital exam or the finger in the bum. And really it took us acknowledging that that's a deterrent for a lot of men. And I think it's only now that we're starting to really acknowledge the barriers that we're creating. And from that, our guidelines really have started to shift towards getting the blood test first. So you don't need to start with the digital exam, with the finger exam of the prostate, but get the blood test. Easier to get, lower the barriers for people to get these tests. And our guidelines for the first time are acknowledging things other than biology, increasing the risk of worse outcomes for Black men. This is the first time where we start talking about social determinants of health, structural barriers to care, poor access as contributing factors. And although it's only a footnote, it's there. And this is really the first time that this is happening, meaning that the guidelines committees, for this one, I'm part of this now, are actively having discussions to address these other issues that have often been kind of pushed to the side as we, quote, focus on the medicine. And really, even when it comes to a biopsy, an invasive procedure, there are other tests that we can do now. And it's really pushing for us to do these other non-invasive tests, blood tests, urine tests, imaging tests like an MRI, so we can really start to identify the people at greatest risk and do less invasive testing, less poking and prodding on the people that may be at lower risk. So there's really an emphasis on using the technology that we have for everyone to improve care and really identify the people that are going to benefit the most and stop bothering the people that may not benefit the most. And this change really came from acknowledging the issues. So I kind of say, we've always been circling the problem, documenting the problem for decades, but it's really addressing the problem that hasn't really been at the forefront of our efforts as a field. And it really came with more discussion of social determinants of health and social factors and understanding how these factors are impacting care, impacting access, impacting treatment, impacting survival. And we're really at the point where people are starting to have this discussion. We don't understand what's happening in our own catchment area, as Dr. Rhodes used that term earlier, but we are starting to say, can we start looking at this to understand what these factors, how all these things come together and impact our patients in a way we haven't thought about it before over the last 20 or 30 years. And really, we've always kind of jumped on biology. It must be there's some difference in biology that's causing these outcomes to be different for Black men compared to other groups. But it's really now, how is the environment, where people are living, the stressors that they're dealing with, starting to impact their biology, and that leads to worse outcomes and worse cancer. So again, we're taking the viewpoint of the environment where people are living, the stressors they're having to deal with, impacting biology, rather than an inherent problem with our biology causing worse outcomes. And it really means that we have to acknowledge and know what we don't know. And that's really something different than the way medicine has always been. It's always been more paternalistic. Doctor tells you what you should be doing next. Doctor tells you what the problem is. But I think we are starting to really understand, or I shouldn't say understand, but more acknowledge that we don't know as much as we think we know. And that has really led to us kind of this idea of missing data, so gaps in our information. And we've always tried to avoid acknowledging those gaps to present the idea that we know everything. But we understand that these gaps in information are causing problems across the board. A busy slide, but basically these two lines show what happens when you acknowledge what you don't know versus ignore it. And that big difference right there is bias, or that's where we start to use our own assumptions to fill in the gaps. And that's where we start to see a lot of problems. And we see this across breast cancer. We see this across prostate cancer. If you start ignoring people or gaps in information, you can get rid of half the data that we're using. So we're trying to use information on only half the population, and in some cases, 5% or 3% of the population for Black men, and generalize that or apply it to a broad population, or a whole group of Black men across the United States. It just doesn't work. That's just not how data works. It's not how we try to work. But ignoring the flaws, the gaps, is easier for us as clinicians, as researchers. So when it comes to even understanding who's at greatest risk, when we start ignoring people that don't have all the information we want in a perfect world, we're going to ignore more than half the people we're looking at. So it really takes us understanding where our gaps are and how it's impacting the medicine that we practice. And that really has to be the first step. And you notice that has nothing to do with the patient. That's what the doctors, institutions, researchers need to do to change so we can provide better care for everyone else. And this really comes back to clinical trials. Clinical trials are kind of the gold standard for how we generate new information. Which drugs work, which approaches or interventions may work for different cancers. So when we look at clinical trials, And we see only 5% of the population in trials are African American, but they're 12 to 14% of the population, a huge gap. And that means we're using very small numbers of men. In some cases, only 150 men out of nearly over 7,000 to understand what new knowledge we gain. You just can't do that. Using 3% and then trying to generalize that or apply that limited information to everybody, we're just trying to fill in the gaps rather than address them. So it really comes down to us acknowledging that disparities in outcomes exist, but also that we have huge gaps in what we know to make things better. And that, I think, is exciting because it provides opportunities not just for community's voice to have a larger impact in how we design research and how we conduct research, but also a huge impact in how providers practice and how institutions practice medicine and how we start to change the way we do things in our field moving forward. So I think at the end of the day, acknowledging that there is more than just biology alone in that environment where people are living, the factors that influence how they get care, the type of care that they get, and biology are all connected, all play together, is important. And we don't understand that well, but we're acknowledging the fact that we don't understand it that well. And I think now is an opportunity where we can start to really drive home the fact that the community's voice matters and the patient's voice matters when we talk about treatment, when we talk about what type of clinical trials would be important. And that preference, those concerns are gaps that we've had this whole time that we've not really talked about. And those are really starting to come to the forefront now. And I think a lot of emphasis is put on clinical trials, but I'd say across the board, every aspect of medicine that I practice as a provider myself need more input, need more information, more voices. And I think now within UCSF and other places as well, we're starting to see opportunities like that start to arise for us to really take a look at how we practice and see that we need more. And that more needs to come from outside of our little bubbles. And at the end of the day, I think those are really the things that have changed for prostate cancer and medicine in general over the last 2-3 years. And I think a lot of that change was forced with other things that have been happening in this country. But they are opportunities for us to really make an impact, which is exciting. So thank you all for the opportunity.
Thank you, Dr. Washington, for your excellent presentation. Later on, we will have our Q&A segment. Go ahead and put your questions in the Q&A box. Colorectal cancer is preventable, treatable, and beatable. Let's learn more from our next presenter, Dr. P. Uwa. Dr. P. Uwa is, Dr. P. Uwa, an associate professor of clinical medicine and gastrointestinal oncology and health disparities research and community engagement liaison for the Cancer Control Program at UCSF. For more information about Dr. P. Uwa's practice and research, please visit her UCSF profile via the link in the program in the agenda. Dr. P. Uwa, please proceed.
Okay, thank you. Let me share my screen here. Slideshow. Okay, thank you everyone here for giving me this opportunity to participate in this event again. I look forward to joining this event. I was here a few years ago, so it's great to be back. So I'm a GI oncologist here at UCSF. I see primarily patients with colorectal cancer and other abdominal malignancies, and the focus of much of my research is on colorectal cancer disparities and looking at diet, lifestyle, and the gut microbiome. Today, I'm just gonna give an overview of colon and rectal cancer, and then just some pearls and a little touch on the topic of the gut microbiome as well. So just starting with colorectal cancer background. So the term colorectal cancer really just refers to any cancer arising in the colon or the rectum, which represent the last part of our digestive tract. So a lot of absorption of nutrients happens in the right side of the colon. Absorption of water, et cetera, happens as you move along. And then the rectum is where we essentially store stool until we have a bowel movement. Colorectal cancer is very common. It is estimated to affect approximately 1 in 20 people every year. And this year it's projected that there will be 106,000 new cases of colon cancer and about 50,000 new cases of rectal cancer and 52,000 deaths attributable to both. This slide is just to show kind of first how we get from normal healthy colon and rectum to cancer, and then I'll touch a bit on how we think about the staging. So we have healthy tissue, but over time, due to different things, which I'll touch on later, we can start to have cells that make up the lining of our colon and rectum. Those cells start to behave abnormally and start to multiply and grow more than they should, and don't have kind of the inherent processes to stop their uncontrolled growth. That's what we call hyperproliferation. If this continues to happen, we do nothing, we get a polyp. A polyp is just an accumulation of cells that have grown more than they should within the colon and the rectum. If we do nothing for that polyp, which is usually benign, then the cells continue to grow, they continue to behave aberrantly, they start to look really funky, and start to do things that healthy tissue shouldn't do, including invading blood vessels, invading more into the lining of our colon and rectum. And that's when we progress to cancer, to adenocarcinoma within the colon and the rectum, or kind of full-blown cancer that's disseminated. The way we think about staging colon and rectal cancer is really based on the extent to which the cancer has grown within the colon or the rectum. So I would think of the colon and the rectum as a tubular structure with different layers within their wall. So stage 1 means that the cancer has really only grown through kind of the first layer of the colon and the rectum. Stage 2 means it's grown through the muscle layer, which is one of the more outermost layers. And then stage 3 means that the cancer has made its way to nearby lymph nodes, which provide drainage of our organs. We have lymph nodes throughout our body and they're all interconnected. And then stage 4 means that the cancer has found a way to leave the colon or the rectum and spread usually through blood to other organs like the liver or the lungs or just the lining of the abdomen. Typically, the higher the stage, the worse the prognosis, the more treatment is needed, and just the worse the morbidity of the treatments used. So colon cancer and rectal cancer are thought to be somewhat silent diseases. So people can have colorectal cancer without knowing they have it until the cancer in the GI tract grows enough to start causing symptoms or spreads to other organs and causes symptoms. Some symptoms can be bleeding from the rectum or bleeding with bowel movements, changes in stools, so observing that your stools are getting thinner or painful or harder to pass. These last few would be symptoms more often of disease that has spread beyond the colon and the rectum. So abdominal pain that won't go away isn't linked with eating or anything else, feeling full or bloated all the time, losing weight despite not intending to, having persistent nausea, vomiting, and then tiredness all the time and jaundice. So who gets colorectal cancer? I mentioned that it's a relatively common disease. Traditionally, it's been thought to be a disease of aging. As we get older, our bodies tend to accumulate kind of somatic genetic changes that can lead to cells just behaving abnormally, and some of the checks that we had in place when we were younger aren't really functioning that well. So traditionally, it's thought to be a disease of aging. And this is actually a graph representing colorectal cancer diagnoses from the last 3 or 4 years. So you can see it's predominantly people 50 and above. And also traditionally, it was thought that younger people were diagnosed really only if they had genetic mutations that would have otherwise predisposed them to it. The big but is that there has been this very alarming rise in the rates of colorectal cancer, primarily actually rectal cancer or left-sided colon cancers affecting people younger than 50. And it's projected actually that within the next 7 years, 1 in 4 rectal cancers and 1 in 10 colon cancers will actually be diagnosed in people younger than 50. I put this graphic up just to show, so this was from the Colorectal Cancer Alliance. They did a survey a few years ago of people with young onset colorectal cancer. I put it up just to show that many of the patients younger than 50 being diagnosed with colorectal cancer are actually presenting with later stage disease, with stage 3 or stage 4 disease. Which can be attributable to partly perhaps maybe more aggressive disease biology, but also it's driven by essentially delays in kind of diagnosing younger people because their providers may not necessarily be on the lookout for something like colorectal cancer in someone in their 30s or 40s. So they're reports of younger people, presenting to the emergency room multiple times with symptoms and kind of having to fight a lot of delays in diagnosis. I put this here as well because this issue of young onset colorectal cancer is one that's it's troubling. There was actually a recent publication, I think it came out last week or the week before, that's actually describing a rise in the incidence of young onset many different cancers. So there seems to be this kind of decrease in the age at which people are getting diagnosed with cancers that we traditionally thought, wouldn't be issues until later in life. We think that genetics doesn't explain it all because it wouldn't, genetic mutation rates haven't changed. So what researchers, including myself, are really looking at are things that I think Dr. Washington also touched on, but looking beyond kind of the individual and looking at their lived environment, the things that they've been exposed to from literally kind of preconception through early childhood and adulthood, and looking at things like the microbiome and just different exposures that could explain this shift. The other pattern is men are still more likely to be diagnosed with colorectal cancer. And the thought behind that is that the prevalence of some of the risk factors for colorectal cancer might be higher in men than in women. And then there are disparities by race and ethnicity for colorectal cancer. So African Americans are more likely than any other racial and ethnic group to be diagnosed with colorectal cancer. And this is a disparity that's persisted for several decades. African Americans are also more likely to present with advanced disease and have still a higher mortality or death rate from colorectal cancer. I added this as well. We are observing disparities affecting Native American, American Indian populations. And then just touching back on this young onset disease, there seems to be a particular rise in young onset left-sided colorectal cancer among Hispanic Latinx populations, as well as other cancers in that group as well. I think this also mirrors some of what Dr. Washington touched on, but when we think about these disparities, whether they're the age-related changes or the racial and ethnic disparities, we're moving beyond just thinking that this is an individual biology genetic problem, because it's not, it can't be explained by just that. But we are thinking about these other factors that can either still affect an individual, like their stress, their access to care, so insurance coverage, health behaviors, but also their environment. So still access to neighborhood resources, but what other people in their environment are doing that might contribute to their own microbiome or their own exposures. And then these bigger picture issues of racism and healthcare systems issues. So it's complex. And I think what we're observing is that something is happening, particularly with regards to young onset disease. And I think researchers are really trying to understand the interplay between kind of these different levels of factors. So going back to colorectal cancer risk factors, I typically think about them in two buckets. So the non-modifiable risk factors and those that are modifiable. So non-modifiable would be things that, you can't really change. So people with a strong family history of colorectal cancer often have a just inherited increased risk of developing it. People who actually know that they have a mutation in their DNA, like a Lynch syndrome mutation or a P53 mutation that would predispose them to getting cancer. That's a risk factor that the individual can't change. And then having inflammatory bowel disease like ulcerative colitis and Crohn's colitis increase the risk of colon cancer because of chronic inflammation in the mucosa. The things we can change would be what we eat and how we live our lives, our lifestyle. So for lifestyle, what we have data for is that physical activity, weight, alcohol, and smoking are linked with colorectal cancer. So people who live sedentary lives have a higher risk of colorectal cancer. These recommendations are from studies of people who've had colon cancer and are kind of in the survivorship setting, but you can extrapolate it to really anyone. And the idea is just move and get at least, 30 minutes, 5 days a week of exercise. Weight, it looks like particularly weight gain in adult life seems to be associated with colorectal cancer risk, but kind of maintaining, a healthy weight for the individual and avoiding unnecessary weight gain. And then alcohol is also linked. There are, guidelines to limit consumption or avoid it altogether if possible. And then smoking, of course. So diet. So I would say that colorectal cancer is one of a handful of cancers that's really tightly linked with diet, in that there's robust literature really describing the associations between the foods we eat and our risk of colorectal cancer. The general guidelines are that processed meat, red meat, a Western pattern diet that's high in animal fat, saturated fats is harmful. And diets that are more Mediterranean, rich in fruits and vegetables and whole grains. So kind of when you're shopping for your bread or your grains, reading the label and really eating whole grains rather than refined is protective. Fish, so dark fish, particularly salmon, protective, tree nuts, and then having adequate vitamin D stores. So what about the gut microbiome? What is it and what role is it also playing? So I think this isn't a new topic anymore, but The gut microbiome really refers to the trillions of microorganisms residing in our gut, as well as all of their genetic material and all of the metabolites and substances produced by those microorganisms. When we talk about the gut microbiome, we are specifically describing the bacteria because that's the most abundant. So we are colonized, we get all of these microorganisms usually at birth via transfer from our mothers during childbirth and labor. And what we've learned in recent years is that we get all of these bacteria from the person from whom we are birthed. And over kind of our early childhood in particular, the things that happen to us. So the type of milk we have, the people in our environment, the foods we eat, really tightly shape what our gut microbiome looks like. And as we continue to age from infancy, toddlerhood to adulthood, the foods we eat, the medications we take, where we live, what's in our environment continue to shape our gut microbiome and shape the numbers of these different types of bacteria that are in there. That's important because the gut microbiome is actually playing a really big role in many normal bodily functions. So the bacteria in our gut help us metabolize the nutrients, help us break down foods to energy. They help in maintaining the integrity of the lining of our gut. And the microbiome is also important in helping our immune system develop and activate, helping our immune system learn what's healthy, what's not, and protects us in our gut from colonization by unwanted bacteria or viruses. In general, a healthy gut microbiome is one that's doing all of these things and kind of playing this almost symbiotic role with us as the host. But as I mentioned, things can disturb this delicate balance. So the foods we eat, the medications we take, early childhood experiences, and even adult experiences, including stress, can kind of shift this balance such that there are more harmful or unhelpful bacteria than there are helpful. And it's that shift that, you know, from us as oncologists, we see this dysbiosis or shift in the gut microbiome is then associated with inflammatory cascades and pro-cancer cascades in the colon and rectum, which then can contribute to cancer. So we think the gut microbiome is very important in not just getting colorectal cancer, but also once someone has colorectal cancer, there's a lot of research now showing that an individual's microbiome can actually impact their treatment outcomes, particularly with immunotherapy, to the extent that there are multiple studies looking at ways to change the microbiome of patients with colorectal cancer to enhance their response to cancer therapy. Moving ahead of that to people without cancer, we are also thinking of ways to use the microbiome as maybe another screening method to identify people who might be at increased risk of developing cancer. So pivoting now to screening, I mentioned diet and lifestyle as two modifiable risk factors, but the other way to decrease your risk of colon cancer, and we think that a majority of cases of colorectal cancer are preventable, is through screening. So why screen? If you remember that slide I showed where it went from hyperproliferation to cancer, that process can take 5 to 10 years. Colon and rectal cancer typically aren't overnight cancers. It takes a long time and lots of chronic changes to develop full-blown cancer. And what that means is that with screening, your doctors can actually catch polyps while they're still benign. So before they turn into cancer, there's enough time to catch them. Or you can still even catch cancer maybe when it's at stage 1 or stage 2 before it's had a chance to spread. And if you catch cancers at an early stage, survival is better, less treatment is generally needed, and because less treatment is needed, less morbidity, fewer complications and side effects. Right now, really touching on this shift in the age at which people appear to be diagnosed, the screening guidelines now recommend that people of average risk start at age 45, and through 75. For the age range 76 to 85, I think it's a discussion with your primary care doctor. The guidelines say it's maybe, but I would say if someone is fit and has a long life expectancy, it'd be reasonable to still think about screening. People over 85 technically would no longer be recommended to screen because of the risk benefit and kind of life expectancies. And then people younger than 45 with high risk, either because of family history, genetics, having inflammatory bowel disease, would also want to consider screening. There are different ways to screen for colorectal cancer. There are invasive ways like colonoscopies and sigmoidoscopies, and then non-invasive ways like stool DNA tests, fecal occult blood tests, and the FIT test, all of which just require a stool sample. The benefit of the more, quote, invasive method, like colonoscopy, where they just put a camera in to the colon, is that they can actually, if they see something abnormal during the test, like a polyp or growth, then it can be addressed during the test. Whereas these other non-invasive methods, if the testing comes back abnormal, you'll still likely have to do something like a colonoscopy to confirm a diagnosis. In terms of the frequency of screening, it really depends on the method used. In general, if you're doing the stool test, these non-invasive tests, you're going to need to screen more frequently. If you're doing the direct visualization, the things like colonoscopies where they're directly using a scope to look inside, then those are felt to be a bit complete, and you can go, like, if they don't see a polyp or anything concerning on your colonoscopy, you can go 10 years before your next one. A CT colonography, I don't see a lot of people doing it, but it's a non-invasive way of basically taking a 3D CT picture of your colon. The downside of it is if they see something abnormal, you'll still need a colonoscopy to confirm it. I think I'm going to stop here. And just to summarize, colorectal cancer is a disease that still disproportionately affects African Americans. It's on the rise in people younger than 50. There are things we can do to decrease our risk. And definitely one of those things is to just maintain a healthy communication with your primary care doctor about when you should be screening and the method that works well for you. Thank you.
Thank you so much, Dr. Piawa, for such an excellent presentation. Now we're going to just shift just a bit. We're going to ask our IT professional, or Dorothy, would you please spotlight or pin David Lee, Dr. Rhodes, Dr. Sam Washington, and Dr. Piawa as we get ready for our Q&A segment. So while IT is getting things set up, why don't we just take a few minutes to stretch? You've been sitting for a little while, move your bodies as a bit of self-care. So let's just take a little time to stretch, roll your shoulders back. You've been sitting down. We just appreciate your attentiveness during this time. But also, this is one of my favorite parts of the day. I'd like for us to talk about who is our prize winner. There will be several. We talked about gift cards or prizes during this time. And our first prize winner is, if I can get a little drum roll and a virtual drum roll, will be Diane Faith. Is Diane on the call today?
Yes, great. Yay. Well, we have a winner. Congratulations, Diane. Okay, we have several questions in our Q&A box. I'm going to start rolling to those. So I believe this will be for all of you. Is there a concern about diet? I believe Dr. Piowa, or about diet, fried or processed foods and risk for colon cancer. They want to know if there's still a concern about this.
Yeah, definitely. I think there is every year, there's still, lots of research really confirming that eating a diet that limits processed foods and that limits high animal fat is protective. And the way I think about it is just thinking about inflammation in the gut and trying to eat a diet that's less inflammatory.
So Dr. Piowa and the other doctors, please chime in. When we talk about processed food, really want to make sure that everyone understands what that means. So are we talking about, because we're a fast food nation, we understand that. So we're looking at the chips, the food that we can take from the freezer and microwave it, or deli meats, things like that. So is that what we're talking about processed food?
Yeah, that's a great question. And I would think when we look at the studies and we as clinicians think about processed foods, we're thinking specifically about like processed meats, like, like bacon and sausage and things that, are like an accumulation of different sources of meats, or deli meat. Deli meat also would fall under that category, or refined sugars, or just, I think the way I go about it is if I can eat a food and it's kind of whole, unperturbed, like in the form that's as close to what it was meant to be, that's what I try to do. Obviously with exceptions, for eating my grains, I need, oatmeal and things that have been a little bit processed. But that's maybe the easiest way to think about it, is when you're shopping or cooking, try to eat things that come in their most natural form. I don't know.
Can I add to that?
Yes, sure.
It's sort of like what you're talking about is eating raw, right? So
yeah,
think about it as like eating raw, because you don't have to do anything to it. And there, once you do something to, in particular vegetables, you lose some of the vitamins, some of the fiber. You're breaking it down by processing it. So try to eat raw if you can. I wanted to just point out, because I think in this space of trying to prevent cancer and folks who have been doing the disparities research over the decades, there really has been this push, and particularly in the faith community, to not eat fried chicken. And I really need to take issue with this right now, because first of all, processed meats, and in particular beef, have been classified as a group 1 carcinogen by the International Agency for Research on Cancer. That's one of our partners in the International Cancer Grand Challenge. That's in the same group as tobacco and alcohol, okay, as determined by IARC. And there is a very clear pathway that can be described of how you get from those processed meats to colorectal cancer. However, what is missing is the described pathway of how you get from fried chicken to colorectal cancer. So I want to caution us. I am going to recommend bake or roast or air fry your chicken. But I'm also going to point out that I think that this is a form of racism, because you don't hear the folks who've been doing this work a long time telling you, don't eat that steak, don't eat that burger. The focus is on fried chicken. And I just would argue that if fried chicken was the big driver of colorectal cancer, we would see it in everyone, because it's not just Black people who eat fried chicken. And yet that tends to be the target of what is advocated for. So I want to caution you about, of course, fried foods, but I want to caution you more about how red meat gets metabolized in the intestine, which can generate some chemicals that look just like smoking cigarettes. So be more worried about beef. Be more worried about beef. Roast your chicken. but you can eat fried chicken and everything in moderation. If you have cardiovascular disease, it's a whole different discussion. But I just want to be clear about that, because I feel in some ways have felt targeted. Like it's because Black people eat fried chicken that we have cancer. Let's look at beef, because that's also has been determined internationally and has been studied at a very high level to be associated with the development of colorectal cancer.
Yeah, I would just add the fried aspect is just thinking about it from saturated fats and what that does. So it's not about like the chicken. You can eat chicken. Chicken's healthy. It's really it's how it's prepared. So I agree. And I love chicken. I eat fried chicken. I think I completely agree. The harm is when we think about animal protein, it's actually more the red meats that's the problem for sure.
Okay, for Dr. Washington, I have a question for you. How do we address the stigmas associated with trust to bring Black men into the healthcare settings earlier? And I really need to ask this question because I've been on my brother for years, and he just avoids the question about, let's go get your prostate. You know, we talk about healthcare. He's always asking me about my hip. But when I come back to him about, well, have you got your prostate checked? And I'm not trying to be funny, but I'm just asking. And he's like, oh, well, when my doctor says so. I said, well, how about if you advocate for your doctor saying it's time to get that exam? How do we do that? I think there's something in his mind that's kind of thinking that's this horrible thing that he's going to avoid.
Well, I think there's a lot of justification for the fear and hesitation, right, that we've had historically. I had this discussion with a patient this week where I don't think me having an MD entitles me to your trust, right? That's something that needs to be gained. And I think it's a larger question of what institutions need to do. I know I've had this conversation with Dr. Rhodes about what institutions need to be doing around mistrust. It's not a patient issue. That's an institution and provider level thing. So getting more involved with community, showing people that we are trustworthy is something that we have to work on. But I think we also have to emphasize the benefits. I tell people, I can take out the cancer if I catch it early enough, right? We can treat the cancer if we catch it early enough. And oftentimes we don't need to do what I call the urologist handshake with the finger. We can do it with a blood test to start to identify people early for some of these things. So some of the other barriers that we are creating, we can start breaking down. Make it easier for patients to see us, easier for patients to talk to us as well.
Thank you.
And can I just add one just thing that I think it applies to every situation where trust is something that people are after. Trust builds at the pace of the relationship. So if you don't have a relationship, you shouldn't expect to have any trust. Think about your own relationships, right? The trust that you have in a long-term partner has to do with what you've been through together. The good, the bad, the ugly, right? But the agenda between the two of you is the same. You want the best for each of you. And the problem is our historical relationship as academic institutions with communities of color is as Dr. Washington pointed out, not one that is, dotted with trustworthy behavior or trustworthiness. So part of what we need to do is not sort of be that one space that is telling you only about one thing. I only want to talk to you about how you're not doing it right. Your brother probably doesn't want to be judged. Your brother wants to be cared for. And the problem is that's not in abundance inside of our clinical spaces. So we're trying to form those relationships outside through UMOJA. And I just want to say that for the folks who have called us because of UMOJA to help get them into care, the phone call from a familiar colleague saying, hey, this person needs something, sometimes expedites that care, changes the tone of the care, right? People want to feel held. And especially if they are worried about cancer or scared about getting checked or whatever. So I think really what we need to build are relationships. So it seems natural that I'm suggesting that you get this done because I always have cared about you. And institutions aren't ready for that. So I think we need to do that together. And sometimes the message, as Dr. Washington said, can't come from a doctor. It needs to come from a friend or a colleague with knowledge and connections. It's about
Thank
care.
Thank you. I appreciate that. Thank you. So, next question we have is, Dr. Piawa, what happens after having 7 polyps found in a colonoscopy for a male?
That would depend on what the polyps were, what type of polyps, what was done with the polyps. I would say that this is a situation where the GI the gastroenterologists actually have clear guidelines as to, what the follow-up would be, when the next colonoscopy would need to be. So that's something I would definitely discuss with, the doctor who did the colonoscopy. But typically you'd need a repeat one at a certain time interval. I hope that helped.
Yes, it does. All right, now you have sparked a controversy with the red meat. So for all of those who endorse the Cattlemen's Association of America, they're asking, what about the quality of the beef? I believe grass-fed beef has many benefits, even though it is beef.
The data we have, as Dr. Rhodes touched on, is at like the molecular level, really showing the impact of the beef or cow-based animal protein on the gut microbiome. So we have data showing disadvantageous shifts in the gut microbiome from eating red meat, and on kind of local inflammatory cascades as a result of the metabolism of the meat. So even if that red meat is organic, grass-fed, single cow from a single farm, it's still red meat, and it's really the meat itself that's the problem.
Okay, and so then another question about that red meat says, so if I decide to eat red meat, since you are suggesting or recommending medium rare as opposed to well done, everything closer to raw?
That's a good. So when we touched on raw, I think we were referring more to vegetables and not like, if you can eat the vegetables as close to raw. With meat, I would say, we give diet recommendations, but we have to think about how sustainable things are. If you're going to eat red meat, try to limit it. So maybe once a month. Or if you're eating it every night, start with once a week instead of every night and scale it back that way. My husband's French and loves red meat, and we have red meat in our household, but it's very limited. So I think start that way. The way you cook it also wouldn't impact that inherent risk. So I think if risk is the concern, it's really how much you're eating and scaling back on that. So eating it well done raw versus not, you're still eating red meat and should scale back.
Yeah, and your gut bacteria are going to digest it in the same way and break it down, and it's going to break down to the same constituent chemicals that we're concerned about, some of which look like cigarettes, like the chemicals that are associated with cigarettes. But char grilling the beef has an exacerbating, I think, an amplifying factor. So the burn marks that you like on your burger, or things that come off the grill, deeply blackening the red meat actually enhances the problem.
Oh my gosh.
So while I want to just highlight what Dr. Piawa just said, it's still beef. So you're still going to get those carcinogens as metabolites. But if you char grill it, and particularly actually for Native Hawaiians and Pacific Islanders, this has been associated with something that is typical in that community. But what I don't know or don't remember from the studies is whether or not that's because the volume of char grilled meat is higher in the population under study.
Okay. Is there any benefit to taking probiotics daily when it comes to preventing cancer for any of you or all of you on the panel?
I can start because I get the question often. So the short answer is we don't know. There are actually, when you look at patients who have had cancer and are getting cancer treatment and taking probiotics, there's a mix. There are studies that have shown that their cancer treatment efficacy is actually not as good in the patients taking probiotics. So I think probiotics, it's kind of a black box because there isn't a lot of regulation in terms of which strains are contained, what the dose of the bacterial strain is, how often you should take it. When you take that probiotic, it's unclear, like, do you take it and then your inherent gut microbiota just clear it anyway because you're not taking enough to colonize your gut. So I think there isn't data to say that someone without cancer taking probiotics is going to change their cancer risk. I would say things like yogurt, which can contain probiotics, are still healthy. Eating fiber-rich foods is a healthy source of prebiotics as well. So again, going back to maybe that idea of raw foods, just getting your prebiotics and things like that from food rather than maybe taking supplements.
Okay.
I don't know if Kim or Sam, you have.
Yeah. How about Samuel, Dr. Rose?
I'd say the same thing for prostate, because I feel like anyone can walk into Costco or GNC. There's going to be at least 2 or 3 prostate health supplements there of some kind. And at the bottom, they'll have that FDA warning that none of this is FDA approved, but it's still costly. So I tell people, oftentimes, if it's breaking the bank, like, we don't have any data to show that any of it helps. None of it is a silver bullet that's going to kill the cancer before it develops. But there may be benefit to it. But if it's breaking the bank and it's causing a large burden, then I would hold off. And I tell people, overall, heart-healthy diet that your primary care doc would tell you anyway is probably going to help prostate, and let's just say everything around the prostate for a lot of the men that I see in clinic.
Dr. Rose?
I don't have anything to add.
Okay. What about GMOs? This is our last question. GMOs, seedless fruits, and plant-based foods that contain soy protein isolate.
I mean, I think to the extent possible with kind of costs, etc., I think eating organic is a healthful way to eat, limiting unnecessary chemicals. In terms of, I missed the other, what were the other things listed?
GMOs and also soy protein isolate. I find that you'll find a lot of the soy protein isolate in protein drinks, protein powders.
Yeah, I think we don't have clear, data linking that to colon cancer risk, but I think the general answer to this question would be avoiding vegetables, fruits that have been processed or that have been exposed to pesticides, and eating organic when you can. Beyond that, there's not a lot of data. Seedless fruits versus fruits with seeds, there's not really data, but you should eat fruits, eat lots of fruits. And then a plant-based vegan diet versus not, I think there isn't data directly linking that to colon cancer risk. The bigger takeaway is really the red meat and processed meat. So, you don't have to go vegan to eliminate red and processed meat.
Awesome. Well, we are at our time. I thank you so much, panelists, for your answers, our attendees for your questions. If you have more questions, please send them to Michelle, and Michelle hopefully can get the questions answered from our professionals. And so now I'm going to turn this over to...
I'm just going to say one thing about the questions. We'll see if they're able to answer any in the chat.
Okay.
Please don't send them to me.
Please, I'm sorry.
I don't have time to do it or try to get them out. Try to just put them in the Q&A, and we'll see if they have time to answer on the back end. Should we not get to something, then please email our office, which the email is in the chat. We'll put it in there and we'll make sure we route it accordingly. Thank you.
Thank you, Michelle. Forgive me. And so now we're turning this over to Marion for the Health Ministries in the Spotlight segment. Thank you all.
So our next session is focused on the work and scope of health ministries. The health ministries is a healing ministry within the church and focuses on the whole person, mind, body, and spirit, and proactively focuses on health promotion and disease prevention. The activities and resources of the health ministries are customized and tailored to the congregation and community's needs. And the health ministry is a health resource for congregations and community, helping those who need information, access to services, healthy foods, and providing resource navigation. The health ministry scope is both local and national and helps advance the Healthy People 2030 National Health Objectives and the Biden administration's executive order to advance racial health equity. We have two health ministers who will be sharing with us. Next slide, please. We will hear from Sister Lenise Yates, who is the president of the health ministry for the Tafatolu Christian congregation in San Jose. We thank the Regional Pacific Islanders Task Force for connecting us with Tafatolu, forgive my pronunciation, and Sister Lenise. We will also hear from Sister Krista Warren, health leader from the Well Ministry International in San Francisco, and Sister Pamela Cross, who is also with the Well. Thank you, Dr. Corinne, for the guiding partnership with the Well. Sister Lenise, please share.
Talofa, everybody. Talofa means greetings in Samoan. And thank you for this blessed opportunity to speak about our health ministry at Tafatolu. We started our health ministry in about 2017, and it started on February 17th by our pastor. And we saw that there was a need for people to get healthier because there was a lot of things going on in the church that a lot of our events, the food was a big factor, and we were losing a lot of people to diabetes, to gout, to high blood pressure. And so the healing of the ministry started. And when I talked to the first lady in my church, Fafota, we had decided to start, we were going to start with baby steps. And so we started these walks. And these 5K walks, they really started to help. And this is everything that we had, like that you're reading here, mental health. And then we also got educators. Then we started these walks, and these walks, they would, every time we did a just cause. And with the just cause of these walks, we did, like if somebody had muscular dystrophy, we did walks for that. Kidney problems, we did all kinds of walks. We did probably a total of 30 walks since we've started our ministry. And these walks, we would have people pin the cause on them, and they would walk around and do a 5K walk. And the ministry has also helped. There you go. Now you see this picture here. There's probably like 30 people. We have lost probably like 10 people since this photo, and they've lost their lives to leukemia. They've lost their lives to diabetes, COVID, when COVID hit. So we thought these walks kind of helped everything, because we started bringing awareness, and we started bringing people in, our own people. That what I mean by our own people, like Polynesians that were doctors, educated, and they started coming in and taking people's blood pressure. We did sugar readings. We did all of this to help people know. We even had somebody come in that was educated to show the people. A lot of my people don't know how to read labels. They don't know how much sodium is in peaches or sugar, for that matter. we couldn't read the sugar, and without us not knowing that, we were like just killing ourselves by by eating certain foods that we shouldn't have been eating. So that was the second step, was try to get everybody educated in that. Let me go to my next slide. So these are some of the flyers that you see that our faith-based health ministry does. And then we started having open gym. Open gym started getting people active, involved in the community. We even had youth come in and help sign up people. We had mentors teaching the kids how to play basketball, how to play volleyball. And as you can see, the flyer right there, that's how we would send our resources out through these flyers and everything. And we had our own page where our own community, then we got other churches involved. And so then our whole congregation, our whole congregation consists of 5 churches. And then they started coming and doing the walks with us. And then we got more people involved, and it was just such a great thing to see. I'll go to my next slide. Then we started offering Zumba classes, health fitness classes at our church. And all this was for free. And then we had open gym, and kids would come out with their parents. And so the ministry grew and grew, and it went through other congregations. And we also had places where people could come get food through the Polynesian Task Force. They helped provide us with food for people. And then in there was like fruits, vegetables. They had like certain type of meats and stuff. But it was a good time for people to come out and also see each other and see what we're going through. And then there was something about connecting with us that when we connected with each other, that all this, we kind of could relate to each other, what was going on with us. And we were also taking care of like our people's needs, that there's certain disease that we have a hard time battling, especially diabetes, especially gout, especially high blood pressure. I'll go to my next slide here. Then we were hosting immunization clinics. The task force helped us bring people in, and we were giving them resources on how they can fight COVID. My minister's wife, she would take people's temperatures. She had her own group, and she would take the temperatures of people when they would walk into church to make sure we had hand sanitizers everywhere. We had resources for people to come and get their immunizations. We were running clinics. We were trying to do everything we can to help ease people's mind about coming slowly back to church, and to help them see that it was okay, and slow, baby steps and stuff that we did for the church. And then another thing we did with the health ministry is that we got the youth involved. Now, knowing, it takes a village. We all hear that it takes a village, and it did take a village. It took the elders in the church with them, and it took the minister and the elders in the church for the youth to come out, and the youth were volunteering to help sign in people. We had my minister's wife also would prepare healthier foods. Now, my people, we love to eat, and we love like we like to eat, I don't know how to say it, and like we eat fospovi. We like to eat like the real food with the fat and stuff. Not all the time, but we enjoy that. And a lot of our health issues come from that, and also our portion sizes. Yes, I know a lot of people, it's a stereotype that Samoans are big people, but if you see a lot of how we eat, that's why. And the food is killing us. And so
Lenise, I'll give you 30 seconds to wrap up, because we do not want to go over into Sister Crystal's time.
Oh, okay. All right. And that's it. And so we just need to make healthier choices, better healthier choices and better portion sizes, and to stick strictly to water. So thank you guys for this opportunity. That's what our ministry has been doing and everything. And I'm sorry about the delay.
Thank you so very much. Sister Crystal and Pamela, please.
Thank you. Good morning. Still not 12 o'clock yet. So good morning, everyone. Thank you for having us. My name is Crystal Warren, and I am the Health Ministry Chair with the Well Ministries International, and we're located in San Francisco. Our pastor is Freddie Carter Sr., and I wanted to inform everybody that we started our health ministry this year in January, along with technical assistance from UCSF Abundant Life, and also from Sister Pamela Cross, who is our clinical health educator and also our health minister. We have done several different classes at our church, and Sister Pam's going to talk a little bit more about that on the next slide. But just a few things: we hit on cancer, we hit on knowing your ABC. She'll go more into that in her portion. And so I just wanted to take the time to just introduce us, the Well Ministries, and also to inform everybody about our new health ministry. So I'm going to turn it over now to Sister Pam.
Good morning, everyone. Thank you, Sister Crystal, for the introduction. Again, my name is Pamela Cross, and I am the clinical health educator and health minister at the Well Ministries. So we're just going to talk about a couple of things that we've started doing in our health ministry, which started this year, and we have done a lot. So we really took off on fire. So it's been a blessing. So we started with every Sunday. We call it a 5-minute recess, where we basically move. We do chair fitness for people who have problems with their knees and their back, or we can also stand up and do it. So we try to pick like a gospel workout, which is 5 minutes. We've done cooking classes. Our first one we did was a black bean quinoa salad. We also did one with the jollof rice with black beans. No, we did the jollof with the black bean brownies. I'm sorry. So during the month of March, which was Colorectal Cancer Awareness Month, we did what we call Fiber Fridays, because I'm sure everybody's been to the doctor and the doctor told me you need to make sure you get more fiber in your day. So we posted Fiber Fridays. So every Friday I would pick a different recipe, usually from the Taste of African American Heritage Cookbook. And it again was Fiber Friday. So every Friday was a different recipe with fiber. We also talked about the fecal immunochemical test, or FIT kits, much easier to pronounce, and the importance of doing that when you get them in the mail or you get them from your doctor. Please, I know it's just like a really messy procedure that you just don't want to do, but the importance of getting that done. We also did Whole Grain Day in the month of March to make sure people were getting more grains in their day. And then April was Minority Health Month, which we did Know Your ABCs, which was your A1C, the total of glucose or sugar in your bloodstream, blood pressure, and cholesterol. And we also did Healthy Spring Drinks, which was amazing. We did different kinds of like infused waters, again, to show people, you can kind of kick up water, not just have to make water bland. So that was really, really good. And what's coming up next for us in September, we're going to do a tobacco and vaping awareness. That'll be on the 4th Sunday. For October, we're going to do breast cancer awareness, and we're going to do a beet breast cancer cooking demo, which will be mostly all whole grains or whole food plant-based. Diabetes Awareness Month in November, which we will talk about diabetes awareness, prevention, mostly probably like another cooking demo, which will probably be from the American Diabetes Soul Food Cookbook. And November, Super Sunday, more jingle, less jiggle. How to avoid holiday weight gain. So in other words, enjoy your holidays, but just less of it, because we don't want to start a new year with excess weight that we gained from over the holidays. So that's what's happening at the well.
Thank you, Sister Pam. And that completes our portion. I know we only had a few minutes to talk, but we try to squeeze everything in. So we appreciate you having us on, and we definitely appreciate UCSF Abundant Life. Also, Dr. K for being such a pillar, and Sister Pam as well. They have definitely pushed us at the Well Ministries International to make sure we encompass everything that we do as a community, and also trying to push this information out to our networks. Thank you.
Thank you.
Thank you very
for having us
much.
today. Thank you.
Thank you very much, Sister Crystal and Pamela, and also Sister Denise, for their great job of sharing and your creative activities that are making a difference. Sister Batiste, will you handle the next agenda item, please?
Yes, I will. Thank you. Thank you, Sister Marian, Lanice, Crystal, for that great session. We are all inspired to receive information useful to our health ministries, and I'm sure potential partners are thinking about ways to further engage. Another potential opportunity for our health ministry is the Abundant Life, HEALS, HEALS, which means Health, Equity, Advocate, and Leaders Project. This is an opportunity for health ministry and community representatives to receive training and help create an education and advocacy project and products. Dr. Corinne Jackson and I are serving as advisors and community investigators on the project, with Anne Marie as the project director and Dr. Kim Rhodes as the principal investigator. For more information, you may contact Anne Marie Charlesworth at ucsf.edu or phone her at area code 415-516-5142. I'd like to give a great thank you to the speakers and attendees, acknowledging the, bear with me for a second, the Cancer Center and the Abundant Life Health Ministry partners. And next, I'll turn it over to Pastor Anadeli to close out in prayer. We'll stay online a few minutes after the closing to allow you to escape things and chat with those on your notes. Follow up. Remember to complete the event evaluation. Pastor Anadeli.
Thank you, Sister Velma Batiste. I want to say thank you to all of you that are participate, that were present for this symposium. And I want to say special thanks to my Ebenezer Community Church member that have taken their time to join us on the Zoom. If all hearts and minds are clear, let us look to the Lord. Father God, in the name of Jesus, we want to thank you for this opportunity and the privilege to gather together at these symposiums, just to learn more about what we need to do to your instruction that you've given us to take care of this temple that you've given us as a steward to. I thank you, Lord Jesus, for every single panel member that have done presentation. I pray, Lord Jesus, that you just continue to give them the wisdom and the understanding that they need, that they will continue to share that experience with the rest of us. For all the churches members, for all the invited members that have joined this symposium today, Lord, I pray, Lord Jesus, that we will not only be hearer of the information that we've been given, but we will take the information to our various churches, to our various community, to our various family, to our various household, and be able to encourage and share with one another what we need to do to keep this temple of the Lord clean. Father God, it is a blessing to be among your people, to share information from various stages that you've provided. I pray, Lord Jesus, that as we are about to depart from one another, but never from your presence, that you give us traveling grace to our various destinations, wherever we might need to go, whatever we might need to do. Father God, thank you for UCSF, the institution that took it upon themselves that they won't only be about what they were built to be, but they will be about the engagement and the sustenance of the community. I thank you for the leadership of Dr. Rose. I thank you for the encouragement of the Abundant Life community member, that you continue to energize us, Lord Jesus, that as we continue to share this information with our various community, our various state, our various nation, but also now to take it to the entire world. Father God, we are our brothers and sisters keeper, and we want to take that and work on it, Lord Jesus. So we thank you for this gathering. Bless us now as we depart from one another, but never from your presence. And we will continue to give you the praise, the glory, and the honor. This prayer we pray in Jesus' name. Amen. Sister Velma.
Thank you. Have a lovely day. See you same time next year.
All right. Thank you all.